Hi and welcome back. For today's video, I am going to be talking all about men's health and topics that you can expect to see on your state boards exam. I personally felt like I had a good amount of men's health questions on my boards, so I made sure to hit on all the topics that I was presented with. I will discuss epididymitis, hydroceles, varicoceles, testicular torsion, testicular cancer, BPH, acute prostatitis, prostate cancer, and a few other things that you do need to know going in to take your exam. At the end of the video, as always, I did include a dump sheet to help supplement your studies. Please don't forget to leave me any questions that you might have. Subscribe to this channel if you found the videos helpful in your studying, and share this with anyone else that you think might benefit. And now on to men's health. Okay, so the first topic that we're going to discuss is epididymitis. This is the most common cause for scrotal pain in adults in the outpatient setting. So symptoms of epididymitis include fever, chills, nausea, unilateral scrotum pain, erythematous, swollen, possibly warm to the touch testicle, more common in sexually active males. So cremasteric reflex is intact and patient has a positive Pren sign. Those two are going to be really important for differentiating epididymitis from other acute scrotal complaints. So those two are really important for you to remember. Epididymitis, it can be acute or chronic, and it's generally caused by E. coli. So treatment depends on the patient. So if the patient is less than 35 years and is at risk for an STI, or if they are sexually active, then we treat empirically pending our testing to cover for gonorrhea and chlamydia. More likely that the organism is going to be gonorrhea and chlamydia in this patient population. And so for those patients, we'll treat with ceftriaxone plus Doxy. If they can't do Doxy, they can do azithro. Now, if they are if they're greater than 35 years old and an STI is not suspected, then we'll be treating for the E. coli. And so treatment options for that include Levaquin or Bactrim. I did include dosages and frequency on here just for your reference. However, remember that you don't need to focus on those for your boards exam. That's not something that they'll be questioning you. It'll be more of the treatment options and that specific patient case. So remember, if they're less than 35, more likely to be gonorrhea or chlamydia related, whereas if they're older than 35, it's more likely to be E. coli, and that will guide you in your treatment. On this slide, we discuss balanitis, orchitis, and Fournier's gangrene. So the first one that I wrote here was actually orchitis, and this is an extension of epididymitis. This is inflammation of the testicle again, but it's most commonly occurs as a complication of mumps in the adult male. So it presents as abrupt onset of fever and erythematous, swollen, tender scrotum. It also will negatively affect the male's fertility. Evaluation and treatment are very similar to acute epididymitis, but just remember that it's a common complication of mumps. So balanitis, this is inflammation of the glands of the penis. It causes erythema, pruritus, ulceration, and curd-like discharge, which we know is often caused by the common organism of Candida albicans. So risk factors are going to include diabetes, obesity, and patients who are uncircumcised. Treatment depends on if paraphimosis is present. If that is present, then it's an urgent urologic referral. If it's not present, then we go ahead and educate on preventative hygiene measures. We can do empiric treatment for Candida if it's indicated, if it looks like they do have that type of yeast infection. If there's no improvement after we treat for Candida, then we can try empirically hydrocortisone. And if no improvement again, then we'll refer to derm or urology, depending for a further eval. And then lastly, Fournier's gangrene. This is necrotizing fasciitis of the perineum that often will involve the scrotum. So this is more common with diabetic patients, those patients who are immunocompromised, or patients with long indwelling catheters. This actually requires surgical exploration and debridement, of course, so we will be referring these patients, but just a term to know. A hydrocele is a collection of peritoneal fluid inside of the scrotum. So symptoms are testicles that are asymmetric. Patient may report mild tenderness and describes the pain as a pressure-like pain. So transillumination, where we use like a pen light, will show a brighter light on the affected side, and that's due to all of the fluid accumulating there. So there's two different kinds. There's a non-communicating hydrocele and a communicating hydrocele. So a non-communicating hydrocele is where the sac is closed around the testicle as it does in normal development. However, that fluid did not absorb back into the body, so there's a lot of excess fluid in the testicle. This will generally resolve by 1 year on its own. A communicating hydrocele, occurs when the sac does not close properly or all the way, as it should. Therefore, fluid can continue to collect there and therefore can cause continuous swelling. This type of hydrocele requires a surgical correction and obviously a more urgent referral to urology versus a non-communicating hydrocele. A varicocele is an enlargement of the veins within the scrotum, and upon palpation, it's often described as a bag of worms. Patient may report a dull or aching pain, and there may be visible atrophy of the affected testicle. So this most commonly affects the left side, and it's often only visible when the patient is standing. Also, this is associated with a decrease in fertility in males. 40% of infertile men are actually found to have a varicocele. So having the patient, when they're standing, perform a Valsalva maneuver or bearing down will help to descend those veins, and it will help in assisting your examination. These patients need to be referred to urology. A Cordy is ventral shortening and curvature of the penis, and it's caused by tightening of the tissues on the underside of the penis. It's often associated with proximal urethral defect. I have a picture there of the hypospadias where the urethral opening is on the underside, and you can see why this would start to cause curvature of the penis. So the further back that the urethral opening is, and generally the more severe the Cordy is, this typically requires surgical correction and a referral. So testicular torsion, this is a true emergency, and that is because time is so important. If this goes undiagnosed greater than 24 hours, 100% of those patients actually end up losing the affected testicle due to necrosis and requiring a surgical removal. So testicular torsion, this is a sudden onset of testicular pain. Patient typically presents with nausea and vomiting, and a physical exam includes an absent cremasteric reflex, erythematous, swollen, and tender testicle, and a negative Pren sign. And if I didn't mention earlier, a Pren sign is where the pain is alleviated when lifting the affected testicle. So in this patient scenario, the pain is not alleviated with the Pren sign, so it's a negative Pren sign. Remember, when comparing this to the acute epididymitis, the patient has a present cremasteric reflex, and the Pren sign is positive in that doing that maneuver actually alleviates the pain. So that's in comparison. Also, for testicular torsion, the affected testicle is generally higher than the unaffected testicle, and this is because the shortening of the spermatic cord occurs as it twists. Testicular torsion most commonly affects between 10 and 25-year-old males, generally active males. Ultrasound is preferred diagnostic tool, though outpatient, your job is just going to be identifying and referring. You don't do the ultrasound there. You don't wait to do the ultrasound because, like I said, time is so important. So you're just sending them to the ER. A UA, this may be normal or it may show hematuria. And like I said again, time is so important. So within 6 hours, the affected testicle can become necrotic. But within 24 hours, 100% of the affected testicles become necrotic. So again, like I said, just urgent referral to the ER. So next up is hernias, and this is a protrusion of an organ or part of an organ through the muscle or tissue that generally contains it. Inguinal hernia is going to be the most common type of hernia, and risk factors for this include Caucasian males, history of hernia, increased intra-abdominal pressure, such as from straining or lifting, an abdominal wall injury, and smoking. This generally presents as a dull pain that occurs with straining or lifting, and most are diagnosed on physical exam. So it's easiest to be seen when the patient is standing. That alternate cough, bulge might appear when the patient coughs or strains, and it makes it easier for your physical exam. And if unclear during the physical exam, then ultrasound is going to be your first line for a diagnostic tool. Symptoms of testicular cancer include a solid, firm, and non-tender mass that does not transilluminate and unexplained weight loss. Patient may also present with gynecomastia and report a sensation of heaviness within the scrotum. So if we suspect testicular cancer, we're going to refer to urology and or a surgeon depending on how severe the symptoms are. We do not want to delay our referral, however, because this is generally a very aggressive cancer. And a term that you definitely want to know is cryptorchidism, and this is an undescended testicle that resides in the abdominal cavity, and this actually increases a patient's risk for testicular cancer. Next up is benign prostatic hyperplasia, or better known as BPH. This is a benign enlargement of the prostate gland that increases with likelihood with the patient's age. Generally occurs in patients greater than 50 years old, and they may be asymptomatic with a very slow onset. So symptoms of BPH include difficulty starting a urine stream, urinary retention, post-void dribbling, increase in urgency and frequency, and nocturia. So upon the DRE or digital rectal exam, generally there is a symmetrical enlargement of the prostate. Tenderness, this may indicate prostatitis, and if the prostate feels hard or mass-like, this could indicate cancer. So a UA, this may show hematuria, but a PSA, it could be normal or high depending. So non-pharmacological treatment, this is limit fluid intake, especially in the evening, void frequently during the day, decrease intake of caffeine or alcohol, smoking cessation, and then also sitting to urinate might actually help the patient to completely void, so you can educate on that as well. There are some pharmacological treatments, first line being the alpha-1 blockers, and they can actually expect to see improvement within 1 week of starting this medication class. So the most common that you will use are terazosin and tamsulosin, and I did include the dosages there. You know that you don't need to be tested on those, but they're there for your reference. And you want to refer these patients to urology if symptoms are unresponsive to treatment or if the patient does have hematuria or pain present. Then those are better to be managed by urology. So patients with prostatitis generally present pretty acutely ill. So symptoms include fevers, chills, dysuria, pelvic pain, low back pain, painful ejaculation, painful urination, dribbling of urine, and enlarged, boggy, tender prostate upon exam. When performing the DRE, if you suspect acute prostatitis, then perform very gently, as you don't want to massage the prostate, as this can actually cause bacteremia and lots more complications for the patient. So very gentle when you do that exam. A urine gram stain and culture should be done on all of the patients that are suspected of acute prostatitis. UA will generally show WBCs and bacteria in the urine. And you want to also rule out gonorrhea and chlamydia in these patients, specifically if they're less than 35 and they're sexually active, or at any age if they have multiple partners, then you definitely want to rule out these STIs. A Mears STAMI test, this is going to be testing for chronic prostatitis. So just a term for you to know. Pharmacologic treatment for acute prostatitis, I included your options there. Generally, they're on treatment for this for 3 to 6 weeks, so quite longer of a treatment. There's Cipro, levofloxacin, or Bactrim as perfectly good options for treatment. Symptoms of prostate cancer include unexplained weight loss, frequent urinary tract infections, incontinence due to an obstructing mass or change in erectile function. And so a mass actually may be palpated on your DRE. It's good to know what a normal prostate feels like. A normal prostate gland is about the size of a walnut, generally smooth or firm to palpation, and is symmetrical. So if it's hard, if it's asymmetrical, if it's enlarged, these could all possibly indicate cancer. A PSA, or prostate-specific antigen, is a screening test for prostate cancer, but it's important to know that there are numerous circumstances that can actually falsely elevate a patient's PSA, including things like urinary retention, urinary tract infection, ejaculation within 48 hours, or vigorous exercise shortly before testing. Also, after performing a digital rectal exam can falsely elevate a PSA. A PSA result of 4 or greater is an indication for biopsy, and this is the preferred diagnostic tool when diagnosing prostate cancer. Also, if we suspect prostate cancer, of course, we will refer these patients as well to urology. All right, so the final topic for men's health is going to be erectile dysfunction. I listed for you here some drugs that actually can cause ED, and this includes Paxil, which you definitely want to know, that's one of the big ones, diuretics, ACE inhibitors, calcium channel blockers, beta blockers, other SSRIs, benzodiazepines, and antihistamines. So there's a lot of drugs that can actually affect erectile dysfunction. Bupropion or Wellbutrin is a good option for patients that require antidepressants, as it is less likely to cause those ED symptoms. So non-pharmacological treatment for these patients, we want to educate on smoking and alcohol cessation, exercising, getting up and moving, weight loss if it's indicated, and then management of their secondary diseases if applicable, such as diabetes or hypertension. Pharmacological treatment, these are the phosphodiesterase type 5 inhibitors. So Viagra, Cialis, these are some common names that we know. Really important to know though is if our patients are taking any of these drugs in this drug class, then they are contraindicated to take nitrates, as this may cause life-threatening hypotension. So we really want to be checking on what drugs our patient is already taking before prescribing any of these meds. All right, so this means that I have reached the end of my discussion. Honestly, I'm surprised that I got through this as quickly as I did. But as always, here is your dump sheet to help supplement your studying, completely dedicated to men's health. And as always, go ahead and leave me any comments or questions down below. Also, please don't forget to subscribe to this channel if it's helped you in your studying, and go ahead and share with anyone else that you think might benefit. I really appreciate your support. As always, I wish you the very best, and I will talk to you soon.